The World Health Organization is on high alert as the death toll from Ebola in West Africa nears 900, with more than 1,300 people infected. It's the worst outbreak of the deadly disease in history. But this is as close as anyone with Ebola has ever come to Boston, a runway 200 miles away in Bangor, Maine, where for the second time in 3 days, this plane refueled before taking an American with the virus to Atlanta for treatment. A third person is being tested at Mount Sinai Hospital in New York City after presenting with a high fever and gastrointestinal problems following a trip to West Africa. But doctors there say it's unlikely to be Ebola. This comes as the CDC issued new guidelines today for airlines for identifying and isolating infected passengers. A spokesman from Massport tells us there's little threat of Ebola spreading in this region because there are no direct flights into Logan from West Africa, and major airlines like British Airways are no longer flying to that region. Here to discuss the threat Ebola poses and efforts to control and treat it is Dr. Daniel Karitzkis. He's the chief of the Infectious Diseases Division at Brigham and Women's Hospital. Doctor, welcome to Greater Boston. Thanks for being here.
You're very welcome. It's a pleasure.
At the outset, let me ask you about the symptoms that are involved in Ebola. I think one thing that makes the disease so terrifying for lay people like me is not only its lethality, but the fact that it begins almost mundanely. How does it present initially, and then how does it progress?
Well, that's true. You know, like most virus infections, it starts with fever, headache, fatigue, sense of malaise, muscle aches and pains. And many other viruses, like the flu, might start the same way. What's different?
Sore throat as well, correct?
Sometimes there can be sore throat. What's really different about Ebola, as with other so-called hemorrhagic fever viruses, is it can then progress to a profound illness with the development of what we call shock, where the blood pressure collapses and where the patient begins to hemorrhage because the clotting factors are used up as they get activated by the virus.
And how much time typically transpires from those early, relatively benign symptoms to the later, more severe ones?
Generally a matter of days, sometimes a week, but usually within days, people who are going to progress to serious illness will develop those symptoms.
Okay. There was a lot of hand-wringing over the decision to bring those 2 American aid workers back to the U.S. for treatment. Was that the right decision?
I think it was the right decision because these are sick people who needed intensive care, and the kind of care that could only be provided here in the United States or in another economically developed country, and they are U.S. citizens. And there's really very little risk that the virus is going to spread from these 2 patients to other people.
Now, my understanding is there's little risk in part because we knew they had the virus when we transported them from West Africa back to the United States, and they were held in this very secure, safe setting, correct, or settings. Should we be concerned about the possibility of people traveling with the virus without knowing that they're traveling with the virus, you know, hopping a flight from West Africa to New York City and then hopping the bus to Boston? Is that a concern people should have?
I think there's a very, very low level of concern about that. Casual contact with infected people is really not the way that this virus spreads. People who are not yet ill but may be incubating the virus are not going to be spreading the virus to other people. Spread really occurs when there's close contact with a sick person, particularly with their blood or body fluids and secretions.
And you say, I believe, not aerial transmission, right? That's not a profound risk?
Right. It's not transmitted.
Not with, say, coughing and spit in coughing, for example?
Exactly.
Okay.
Right.
Are we doing enough at this point to keep the virus from getting into the U.S.? I know that there have been guidelines issued, as we mentioned a moment ago, but I believe that there are still some flights into and out of West Africa. I don't think Americans have been told under no circumstances should you travel there. I'm also not sure how rigorous the screening is at airports. My understanding is it's largely visual. Should we be doing more, or for the reasons that you mentioned, is the screening we're doing enough?
Well, I think that the guidelines and approaches that the Centers for Disease Control have recommended are appropriate, and the main thing is that people who are returning with febrile illness from West Africa should be evaluated and make sure that they're not sick with a variety of infectious diseases, that particularly malaria, which would be more likely to be causing problems than Ebola. And again, unless people have been in close contact with sick individuals in Western Africa, they're not going to be spreading or carrying Ebola.
I want to ask you about these experimental treatments that the two Americans we mentioned a moment ago are currently getting. Can you, for lay people like me, again, explain what those treatments involve? I believe tobacco is involved, correct?
No, it's an antibody.
So I apologize. No, I thought I read that tobacco was involved in these.
It may be that the antibodies are being produced in tobacco cells with a tobacco mosaic virus. I'm not certain about that, but if tobacco is mentioned, that's probably the context. But essentially what my understanding is what they're receiving are some synthetically produced antibodies that would attack the virus and prevent the virus from spreading from one cell to the next. These antibodies have been studied in monkey models of Ebola, and the preliminary data show that the antibodies can be effective in treating the monkeys. Of course, this is the first time these antibodies have been given to people.
Should those same antibodies be being made available right now to individuals who are suffering from Ebola in West Africa?
Well, I think that's a complicated question. I think what we need are well-done clinical trials that show that the antibodies are safe and effective in the treatment of Ebola. Because there is currently an epidemic, this would seem to be the best situation in which you could demonstrate that the antibodies are effective. But there has to be the capacity to manufacture enough of the antibody and then deliver it in that setting.
How close are we to a vaccine that would keep people from contracting this?
There have been a number of successful developments in the discovery of an Ebola vaccine, and but again, the challenge is demonstrating that the candidate vaccines are actually effective. And since Ebola tends to come and go and usually doesn't stay around for a long time, you can show that a vaccine candidate might induce antibodies which could be protective. You can't prove that they're protective unless you have an opportunity to study it in the setting of an outbreak.
All right, my last question for you briefly. I know that you've done a lot of traveling working on HIV in the past. If you got a call from the World Health Organization saying, we need you here in West Africa, we need your expertise to help us manage this, would you have any qualms about going?
I would be comfortable going, knowing that using the appropriate personal protection gloves and gowns and masks and so forth, that you can be reasonably certain that you're not going to acquire Ebola.
All right, Dr. Daniel Kritzkes, thank you for joining us and putting some of us, including myself, a little bit more at ease about this terrifying disease. Appreciate it.